I'm Taormina. I'm one of the EMS Medical Directors with Regions EMS, and today we're going to be talking about ultrasound. Ultrasound initially started with Regions EMS back in 2021 with our fellows using our portable ultrasound devices out in the field during cardiac arrest. Well, in 2021, we figured, why can't we train medics to be able to do the same thing? So ultrasound was one of the only changes that we could do with regard to cardiac arrest management in the emergency department. Our paramedics were already giving all of the medications, they were using the Lucas device, but we like to be able to confirm cardiac standstill with ultrasound in the emergency department. Taking that to the streets was the next level in ultrasound use in the pre-hospital setting. With our program, we have implemented pre-hospital ultrasound use primarily for cardiac arrest management. We're able to use our ultrasound to assess in multiple different spots along the chest to look for cardiac activity while resuscitation is ongoing. We have found that sometimes where we thought that there was no pulse, the heart was actually beating very, very slowly, and this changed management overall. And those patients then were transported to the emergency department rather than having terminations be done on scene. The use of pre-hospital ultrasound has also been extremely helpful with regard to calling medical control for termination requests. It's increased confidence in our paramedics on the street to be able to use this tool to confirm no cardiac activity prior to calling for terminations. Because of our successful utilization of the cardiac pre-hospital ultrasound, we're very excited to be expanding in the future to include a multitude of other studies. Some of these being fast exams for trauma patients to be able to see if there's blood in the abdomen, IVC measurements to help out with firefighter rehab and to ensure that our firefighters are properly hydrated before returning to duty, and procedural guidance for ultrasound IV placements. Now we're teaching all 4 cardiac views for a couple of different reasons, but the best part about knowing how to do all 4 views is that no matter your patient's anatomy, you should be able to find the heart using one of these 4 views. Traditionally, subxiphoid was the only view that was taught, but in some patients it's very hard to get that view. So we teach the around-the-clock method of starting with your parasternal long, moving to the parasternal short, the apical 4-chamber, and then the subxiphoid view. And your goal is to be able to get a good look at the contractility of the heart in one of these 4 views. It's important not to spend too much time in one in particular view and move on to the next if you can't get a good view. All right, so first step in pre-hospital ultrasound is making sure that you've got your probe hooked up to your pad or your cell phone, whichever one you're using to be able to get your view. So once you turn your actual machine on, you're going to be able to see that your probe is connected to the screen. Next, you're going to choose whichever study that you're using. So to start with, we're going to do cardiac. So you're able to select cardiac mode on the iPad, and that's going to put it into the correct context to be able to get the best view possible. The best way to be able to hold your probe in the back of a moving ambulance is to slide your fingers down towards the bottom of the probe, and you can anchor on the chest wall with the rest of your hand here, just like this. And that allows for stability, because we know in the back of a moving ambulance it can be difficult to hold your probe as still as possible, and that'll help you get the best image. To be able to have the ultrasound sound waves bounce correctly off of your target, which is the heart, you need to use lots and lots and lots of ultrasound gel. So we've got ultrasound gel such as this. You also have packets, and in a pinch you could also use surgical lube as well. So to be able to start here, you're going to put a generous amount of ultrasound gel to the left of the sternum. First, we're going to go through the parasternal long view. You want your probe to the left of the sternum with the indicator towards the patient's right shoulder. Now this view can be obtained even with the Lucas device on. It's just going to be directly to the side of the Lucas device. This view gives you a great look at your left ventricle, your left atrium, and the top of the right ventricle. You're able to see your valves moving, which is helpful to determine if there's good forward flow in a cardiac arrest. This view is also very useful in determining if there's a pericardial effusion, which is fluid, potentially blood, around the outside of the heart. Moving forward, we're going to be talking about the parasternal short axis. So for this view, you're going to march around the clock, you're going to turn your probe, so the indicator now is towards the right shoulder of the patient, and the probe stays on that left sternal border. This view is kind of like you're looking down through the heart, seeing a donut almost. The parasternal short axis view is very helpful to look at contractility of the heart. You'll actually be able to see those papillary muscles squeezing blood throughout the bottom part of the heart, and that's showing you how good the heart is squeezing. So with your short axis view, you're able to directly compare both the right and the left ventricle. In a normal healthy heart, the right ventricle should be smaller than the left ventricle. If you're getting this view and you see that your right ventricle is bigger than your left ventricle, you're gonna want to think about what things could be causing strain on the heart. Now this could be fluid overload, or this could be a pulmonary embolism causing that right ventricle to have backup of blood and making it look bigger than the left ventricle. With prehospital ultrasound, we know that everybody's anatomy is slightly different. You're not going to be able to use your probe at the exact same spot in every single person. The best way to be able to find this view is to start in the second or third rib space to the left of the sternal border. If you're having a hard time finding this view, you can slide down a rib space or slide up a rib space to be able to find where that heart is squeezing inside of the chest. Some people with heart failure have very, very big hearts, and their heart is going to be sitting down lower into their chest wall. So you might actually have to go down several rib spaces to be able to get that good view. You're also able to get a better view sometimes depending on where patients are at in their breathing cycles. And you can also physically manipulate the patient to be able to make the heart closer to your probe by having them lean slightly to the left. This can even be done in cardiac arrest with the Lucas on, where you can lean the entire patient towards the left with the Lucas device ongoing. And that should pop that heart right up against the chest wall and make it easier for you to get the image that you want to make clinical decisions. Next up is our apical 4-chamber view. The apical 4-chamber view is a great alternative to the subxiphoid view if the patient's belly is expanded with gas and you're having trouble getting that view. So you're going to take your probe, it's going to be in the 3 o'clock position, and your probe is going to be underneath of the pec on the left side here. Now the heart sits in the chest kind of like this, so that probe is going to need to be angled up towards the patient's left shoulder. This view can be a little bit difficult to obtain, and if you're not getting a good look at all 4 chambers, you can turn your probe counterclockwise 5 degrees, and sometimes that's helpful in bringing that heart into view. Another tip or trick that you can use to make that heart pop is to turn your patient slightly to the left to pull that heart kind of up against the chest wall for you to be able to get a good look. This view is especially useful in assessing overall contractility of the heart because you're able to see how all 4 chambers are working independently of each other. And last but certainly not least, we have our subxiphoid view. So for the subxiphoid view, you're going to want to be looking at the heart kind of through the abdominal area. The best way to get this view is to start at your xiphoid process and just pop right underneath of it. Some people would obtain this view by coming up from the abdomen, tracing up to find your heart, but with that view, you're actually pushing any gas that's in the bowels up towards the heart, and that can obstruct your view. Remember, ultrasound waves do not like to go through air, so it's going to be difficult to see. If you're also having trouble with this view, you can use your liver as a window. So ultrasound likes to go through the tissue of the liver. The liver is on the right side of the abdomen of your patient. So if you take your probe in the subxiphoid view and slide it just towards the right and angle up towards the patient's left shoulder, you can use that liver as a window to help you get a better view of the heart. Another tip would be to have your patient take a big deep breath in. And what this does is it pushes the diaphragm down and pushes that heart closer to your probe. Now this is different than in the parasternal long view, where it's actually better for them to be taking a big deep breath out, giving you a better view of the heart in that parasternal long view axis. There are 2 functionalities of the ultrasound itself that help you to fine tune to be able to get the best image possible, and that is gain and depth. With ultrasound, you're able to adjust the gain to be able to fine tune your image to get the view that you want. On your ultrasound machine, in the preset that says cardiac, it adjusts your gain to what it thinks is going to give you the best view possible, and that's around 50%. So with gain, you want to be able to see the blood in the ventricles as black, the heart muscle in the valves is gray, and the pericardial sac is white. If you have too much gain, your image is going to be completely washed out and look kind of white, and you can't differentiate between the different structures. But not enough gain, and all of your image is going to look black and everything will look like blood. So you really want to be able to fine tune that image to be able to see blood as black, pericardium as white, and muscle tissue as gray. The second adjustment you can make is to the depth. Now, on the side of your ultrasound screen, there are several hash marks, and those equate to centimeters that the ultrasound waves are shooting into the chest wall. Now again, your cardiac preset is optimize the depth to be able to see the heart in the middle of the screen, but you may need to make some adjustments based on which view of the heart you're looking at. The parasternal long and short axis view are closer to the chest wall, so you're going to need less depth. However, when you're in your subxiphoid view, you have to go through a lot more tissue in the abdomen to get up to that heart, so you're likely going to need to increase your depth. The best way to do this is to increase your depth until you start to see those ventricle movements, and then you can fine tune from there to bring the heart into the center of the screen. Let's talk about lung ultrasound. Ultrasounds of the lungs can be helpful in determining if there's fluid in the lungs or if there's a pneumothorax on trauma patients. Thankfully, lung ultrasounds are much easier to obtain than cardiac views. You're going to have your probe marker towards the head of the patient, and you're able to look at the lungs either from the anterior or from the posterior chest wall. Now, for trauma patients, most likely they're going to be laying on their back, and you can look at the lungs right underneath of the clavicle on either side of the anterior chest wall. Ribs on ultrasound creates a shadow underneath of them, and you're going to be looking for the lung tissue in between that. Now, when patients are taking deep breaths in and out, you should be able to see the lungs sliding between the ribs. Sometimes in the back of a moving ambulance, it can be difficult to see this, and then we can use another ultrasound tool called M-mode, which should be able to show you if you're having actual lung slide. If you don't see lung sliding, then you should be worried that there may be a pneumothorax. With M-mode, if the lung is sliding appropriately, you should be able to see movement, and it looks kind of like waves on a sandy beach. If the lung is not sliding, you're not going to see any movement, which will look like a barcode on the screen. So with normal lung sliding, you're going to see the pleura sliding along the lung tissue between the two ribs. This can look like shimmering or like ants on a log. With normal lung tissue, you will also see horizontal lines throughout the depth of the lung, and those are called A-lines. Those are normal. With lungs that are filled with fluid, you will see something called comet tails, also known as B-lines, that start at the top near the pleura and then shoot down the base of the lung. And this is a sign of volume overload, like what you see with CHF exacerbations.